Hi, my name is Jennifer Lander, and I am a master's in nursing student working on a project to improve miscarriage care for women who go to the emergency department at DH. I've had the pleasure of working with the team on this project. The team is made up of two labor and delivery nurses, Elizabeth Joseph and Francine Kane. I'm also working with Jamie Bailey, who is the child life specialist in the emergency department, Reverend Sky Murray, who is the CHAD chaplain for DH, and Jana McWhirter, who is the nursing educator for the emergency department. Farah DeSalle is the perinatal educator for the state of New Hampshire. We have been working hard the last couple of months to try to design a program to meet the needs of both the patients who seek care and the staff who care for them in the emergency department for an actual or impending miscarriage. Your input has been very valuable to the process. I'd like to start out by showing you some of the data that I've collected along the way. The graph that you are looking at right now is from the data analyst at Dartmouth. He was able to pull together for me the base number of miscarriages that are seen in the emergency department each month. This is only a base number because there are 617 possible billing codes that could be placed in a patient's record if they came in with an actual or impending miscarriage. There is a great deal of potential ambiguity when looking at billing codes to determine if a woman was seen for an actual or impending miscarriage. For example, if a pregnant woman presents to an emergency department with a complaint of vaginal bleeding, but the pregnancy or gestation is not documented, there is no way to accurately identify this patient as having a potential or actual miscarriage. As a result, we can determine that there are at least 4 miscarriages seen in the ED each month, but we theorize that the numbers are actually much higher. The second graph represents the baseline surveys that were done by both the staff and the patients. The staff and the patients were asked the same questions about care, and it was interesting that many of the answers were different. 25 staff members responded to the survey and 5 patients. While the numbers are not statistically significant, the results were helpful to determine where the needs were. The first question I asked was whether or not care was given that was patient and family-centered. Most of the staff felt like they were providing high-quality family-centered care, while most of the patients actually felt that they did not receive it. For the second question, I asked about timeliness of care. 2 out of the 5 patients said that they felt they received timely care, while most of the staff felt like they were delivering timely care. The third question was whether or not there was a sign available to alert staff that there was a loss before entering the room. Some of the staff were confused about this question. The answer is that there is no marker to ID losses. The fourth question was whether or not bad news was delivered with compassion. Most of the staff felt like they were achieving this goal, while only 1 out of 5 patients reported that she received it. The fifth question was whether or not education and supplies were given for post-pregnancy needs. Supplies may include mesh underwear and appropriately sized pads. None of the patients felt that they had received those supplies, while half of the staff felt like they provided the supplies and education. The sixth question was about the supplies and education on the disposition of remains while in the emergency department. A couple of the staff members said that they felt like they were providing this intervention. However, none of the patients reported that they received this intervention. The seventh question was about education or supplies related to the disposition of remains after discharge. Both the patient and staff were in agreement that this is not done, or that it was not applicable. Question number 8 asked if there was a safe and private place for patients to express emotion and for exams. The staff felt that most of the time that they were providing a safe and private place, while less than half of the patients felt that they were provided a safe and private place. Question 9 asked about offering and receiving inpatient resources, such as child life, chaplaincy, and social work. About half of the staff felt like they were providing patients this intervention, and the patients did not feel that they were receiving any of these services. The last question was about community or outpatient resources being offered. Some of the staff felt that they were providing it, while all the patients reported that they had not received these resources. As a result of the data we collected, the group and I put together resources that the ED staff would need to provide comprehensive care to patients experiencing a miscarriage or impending miscarriage. This list included a poem entitled "What is Presence?", a quick reference guide of what to say and what not to say, a checklist that the ED can go through to ensure that each patient is given the resources and supplies and information while in the ED as well as after discharge, a form for midwives and doctors to fill out so that the patients can retrieve any fetal remains they wish to, a flow chart that the staff can follow to provide miscarriage or impending miscarriage care, a list of inpatient resources for all the ED staff, a supply list for the collection and processing of fetal remains or products of conception that are present while in the emergency department. This will also include information on options for respectful disposition of remains. This form talks about cremation, funeral homes, home burial, or hospital disposition. There is also a section for additional educational resources on perinatal loss. Also in this binder is a copy of the slides from my recorded presentation by Farah DeSalle, which will be made available for all staff members to watch. Her presentation reviews trauma-informed care, communication, the qualitative and quantitative data from this project and others like it, and additional resources to both in the hospital and in the community related to perinatal loss. Her slides are followed by pictures and descriptions of all the supplies that are available for staff for memory making. Also included at the end of this binder are the list of New Hampshire and Vermont crematoriums and funeral homes, as well as options that are available around the state for free cremations for those who experience perinatal loss. At the end of the book, I have included the guidelines, which all my survey questions are pulled from. It's called the Interdisciplinary Guidelines for the Care of Women Presenting to the Emergency Department with a Pregnancy Loss. This document was written by the National Perinatal Association. Lastly, there will be a copy of the falling leaf laminated door card, which will be placed outside the door to alert staff that a patient is experiencing a loss. This next slide shows what is written on the quick reference guide for staff on what to say and what not to say. We wanted to give them some ideas of what exactly they could say and what to avoid saying. Things like, "I'm sad for you," "How are you doing with all this?" or "I'm sorry" would be recommended, while anything that starts with the words "at least" or phrases like "you are young, you can have others," or "you have an angel in heaven" would not be recommended. This flow chart is the miscarriage or impending miscarriage process flow for the emergency department. Everything in pink are the interventions that the staff should be providing every time, and the different colors represent where there is a clinical judgment based on individualized needs. For example, the purple is the need for appropriately sized sanitary napkins or mesh underwear with the presence of any vaginal bleeding while in the emergency department. Supplies, education, and resources are also on this flow chart. It encourages staff to reassess the supplies, education, and resources at discharge as well as while the patients are in the ED. This is an image of the falling leaf door card that will be placed on the door of all patient rooms to identify to any staff who may enter that the patient and family are experiencing a loss so that they can provide appropriate compassionate care. This slide is a lot to read, but I just wanted to highlight some of the important things on this worksheet. This is the worksheet for staff to fill out when they have a patient who presents with an impending or actual miscarriage to the emergency department. It gives us information on the patient's identifiers, their OBGYN history, whether or not they have a support person present, and encourages them to contact a support person for the patient. It assesses whether the patient wants follow-up for emotional needs related to care. It also encourages staff to contact and provide one of the following: chaplaincy, child life, or social work. It gives instructions on the disposition of remains and encourages providers to fill out the proper forms to provide options to patients. It encourages staff to provide the patient education folder and to contact either the birthing pavilion or child life to help with any memory creation that can be done. Lastly, it encourages staff to provide supplies for vaginal bleeding as well as collection of fetal remains while in the emergency department and after discharge. All these forms, once filled out, can be collected by child life, and follow-up will be provided by chaplaincy. These are pictures of the miscarriage patient information packets that will be given to all patients experiencing an impending or actual miscarriage. On the left is any physical or emotional information regarding miscarriage. On the right side is information for collection of fetal remains at home. The staff will be advised to remove information on the right that is not applicable to the individual. Here on the right side is an image of the purple box that fits a specimen cup. The specimen cup can be used to hold fetal remains. Other items included in this packet are 2 poems about loss and miscarriage. There are also 2 informational packets on both learning you will miscarry and miscarriage, which are written by Resolve Through Sharing. There is a list of community resources for patients, both Dartmouth-Hitchcock related and non-Dartmouth-Hitchcock related. There's information on collection of fetal remains at home and information on respectful disposition of remains. There is also contact information for chaplaincy and child life. This is an image of a pamphlet called Learning You Will Miscarry by Resolve Through Sharing. It goes through the possible medical terms that a patient may hear, and it talks about being sure that a miscarriage is happening. It gives choices about how miscarriages can happen based on medications or procedures. It also encourages patients to take their time about making decisions. It talks about how much bleeding is too much and gives information about miscarriage comfort supplies, as well as emotional and physical needs after a miscarriage. The second pamphlet, also written by Resolve Through Sharing, is called Miscarriage. It gives more information about the frequency of miscarriages and the different ways that people may view the experience. It lets patients know that what they may feel like after a loss, both physically and emotionally, and gives information about how to find meaning and answers after a loss. Just Those Few Weeks is a poem that will be included in the packet and is about miscarriage. For the sake of time, I will not read it to you, but I encourage you to pause or go back to read it. This is the second poem that will be included, and I also encourage you to pause or go back and read it if you would like. This slide is a list of Dartmouth-Hitchcock community resources for patient, and the names on the left are providers that work in psychiatry and specialize in perinatal loss. The Women's Resource Center on the right is an excellent resource for books and for a perinatal loss support group. Also very helpful in the area is the Upper Valley, is the Pregnancy Center of the Upper Valley. It offers a variety of resources, but the one I would like to point out is that they also provide individualized pregnancy loss counseling. This slide shows the online resources that will be provided to patient and includes the international sites related to pregnancy loss support. One of the sites that I found particularly interesting was the stillbirthday.com because it provides very sensitive pictures related to loss and provides options for families to look at images of what their child may have looked at a particular gestational age. This slide is quite wordy, but I just wanted to give you a couple highlights. This is the form about the collection of fetal remains at home, which will be given to women if there's an expectation that they may be passing remains while at home. It gives supplies that may be given to them while in the ED and how to use them. In addition, it also gives a list of supplies that can be used at home if they do not receive them in the emergency department. This is one of the other forms that's included, and it's about the options for respectful disposition of remains. It talks about the options a family have to care for any remains that might be collected. It goes into more information about what hospital disposition actually means, options for cremation or funeral home, home burial, and the pathology process for retrieval of remains. Thank you for taking the time to watch and listen to this presentation. I know that a lot of this information can be challenging to listen to. In my experience and research, I've found that many families feel that having options and being able to make choices that meet their needs can assist in the bereavement journey. I would love to hear what you think about this implementation plan. I will be sending you a link with a survey in your email. The survey is the same as the first. I would like you to fill it out based on your experience and how it might have been different if the improvement plan had been in place. Again, thank you for your time and your contribution to this research. Please reach out to me if you have any questions, comments, or concerns.